to a GSA Momentum discussion on the GSA Toolkit for the Management of Obesity in Older Adults. Momentum discussions highlight topics experiencing great momentum in the field of gerontology. Today's program will be approximately 60 minutes in duration, and a handout including a link to the toolkit where you can find many references and resources is available to you. We are grateful to Novo Nordisk for their support of the toolkit and today's program. My name is Jen Pettis. I'm the Director of Strategic Alliances at the Gerontological Society of America, and I am delighted to serve as the moderator for today's Momentum discussion. Please join me in welcoming today's panelist. Joe Nadglowski is the President and CEO of the Obesity Action Coalition. Dr. Rodolfo J. Galindo is an Associate Professor of Medicine at the Emory University School of Medicine and an investigator at the Centers for Diabetes and Metabolism Research at Emory University Hospital Midtown. Dr. Catherine N. Porter-Starr is a dietitian and an Assistant Professor of Medicine and Geriatrics at the Duke University School of Medicine and a research health scientist at the Durham VA Health System. And Dr. Fatima Cody Stanford is an Associate Professor of Medicine and Pediatrics at the Harvard Medical School and an obesity medicine physician scientist at Massachusetts General Hospital. Thanks to all of our panelists for joining us here today. Welcome, everyone, and thank you for being here. And thank you for your ongoing contributions to the GSA Toolkit for the Management of Obesity in Older Adults. A chronic and often untreated disease, obesity has emerged over the past half-century as a major source of morbidity and mortality in the United States for individuals across the lifespan. Let's start with talking a bit about what makes obesity a particularly complicated issue for older adults and what unmet needs the CARE Toolkit addresses. Doctors Stanford and Starr, I'd like to direct this first question to you. What makes obesity a particularly complicated issue for older adults? Dr. Stanford, let's start with you.
Well, absolutely. First of all, it's a delight to be here with you and discussing this really important issue, which is obesity as a disease. And so I think the first major issue is that for so long, obesity wasn't recognized as a chronic disease. And as such, we were putting the onus on individuals to treat themselves because, of course, it was within their willpower to be the weight they wanted to be. As we've recognized obesity as a chronic disease, most recently by the American Medical Association in 2013, we recognize that this is a complex, multifactorial, relapsing remitting disease that does require treatment. And as older adults, just because you're an older adult doesn't mean you don't warrant therapy. And what that therapy looks like can vary from individual, meaning it can be lifestyle or behavioral, it can be pharmacotherapy or even surgical interventions. And for so long, we've denied these to older adults because we've thought it's just a matter of just eating less and exercising more. So I think understanding the complexity of the disease, recognizing it as a disease is one of the key challenges amongst all individuals, but particularly amongst older adults.
Dr. Starr, can you add to Dr. Stanford's thoughts?
Absolutely, and just to second, it is such a pleasure to be here today and talking about this very important issue. So the area that I really want to emphasize is as it pertains to the metabolic and the physiological changes that occur with older adults and the impact that obesity may have on those individuals. So what I mean by that is we know that there are physiological changes that occur where we start to see a reduction in muscle mass, where we start to see an increase in adiposity that naturally occurs with aging. Some of the other things that we also see are these anabolic resistance to the ability to build muscle and maintain muscle. And so what we're seeing is this decline in potential muscle strength and muscle function, and this increase in adiposity that infiltrates the muscle, so impairs that muscle even more. We know that older adults really want to maintain their independence. That is one of the the biggest things that we hear in the clinical setting, and when we talk to our family members and our friends. And what we also know is that there are also economic and sociological changes that occur, and also these economic components and sociological components, distance to a gym, whether or not we have ability or even access to food when we're making these recommendations. And I think that those are the things that we oftentimes miss when we are thinking about our older adults. So again, just that we know that there are going to be these physiological changes that occur that make our older adults a unique population, and that when you've seen one older adult, you've really truly only seen one older adult. They're very heterogeneous. And that we do know that there are some constraints in regards to the economic conditions and even environmental conditions that we have to take into consideration when we are thinking about obesity management in our older adult population.
And Dr. Stanford, I'd like to turn back to you and ask if you could share a little about the unmet needs around caring for older adults with obesity and overweight, and how the KAER Toolkit addresses those needs.
Absolutely. So the unmet needs surrounding care for patients with obesity that are older adults is number one, most physicians and other healthcare providers don't know how to address the disease. We weren't educated about it in medical school, residency, fellowship for those that are NPs, PAs. In addition, they weren't educated. And so you're dealing with a workforce that doesn't know how to address this disease. That's one of the main key issues. But even when we delve a bit further, looking at particularly the Medicare population, which is primarily older adults, but can be other populations, we recognize that Medicare does a poor job of covering access to therapies. Particularly pharmacotherapy for the treatment of obesity is something that is contraindicated or particularly excluded under Medicare Part D. What I find is a lot of stress and strain for my patients that actually have the disease of obesity, are undergoing therapy when they're with their employer-sponsored insurance, decide to retire, go on Medicare, and no longer have access to therapy. It is devastating. And just this morning, I have a 72-year-old patient who's done very well on pharmacotherapy, now is on Medicare, and she's finding that her medication, which she was paying $30 a month for, is now going to be $780 a month. That is cost prohibitive. She's devastated. I don't have a strategy by which to help her address this, but for 72 years, it's taken us a long time to find a therapy that works. And here we have it, but no, you know what? Medicare says no. You have a therapy that works, but obesity is not a real disease, and we're not going to treat it. And so that's really problematic. And it's a lot of stress and strain on me because I want to deliver the best care for my patients and recognize, as Dr. Starr mentioned, the heterogeneity of this population. When I find the right therapies that work for an individual, I would like to continue those therapies to treat the chronic disease that is obesity. But I'm unable to do so. The resources that are there are not accessible to older adults. And so this is one of the key issues that I deal with as a physician that's here to care for my patients with obesity exclusively, and making sure they get the best possible care and having restrictions on how to really pull that off.
Well, we've learned about the unique needs of older adults when it comes to addressing their care, and how the KAER Toolkit can help teams provide comprehensive interdisciplinary obesity care. Next, let's move through the 4 sections of the KAER Framework. That is Kickstart, Assess, Evaluate, and Refer, or KAER. The first K, kickstarting the obesity conversation. What influences initiating a conversation with an older adult about their weight or obesity? Joe, I'd like to turn to you first and hear a bit from you of how stigma associated with obesity influences patient care, and what can healthcare teams do to address that?
Thanks, Jen, for asking such an important question. I think one of the realities that we face in this world is that in our rush to make obesity bad, somehow we made the people living with obesity bad. And that is a major challenge. Most people who struggle with obesity will report that they have had a poor or difficult conversation with their healthcare provider on this, that their healthcare provider has shamed or blamed them about their body weight or about their obesity. And so we have to recognize that that is an issue, right? And we have to move towards, as Dr. Stanford and Starr explained earlier, that this is a much more complicated condition. And it's not just about some personal failure. This is about biology. This is about a medical disease that people need help with. And so I challenge every healthcare provider, as you go to engage in these conversations about obesity with your patients, to do so recognizing they've likely had poor conversations in the past. They've likely been mistreated in a healthcare provider's office. And so start off very carefully around this. You can ask permission to have this conversation. Is it okay that we talk about your weight today? And actually read into the patients how they're reacting to these conversations. And if you see some pushback around the topic, recognize it's not likely about you personally, but it's likely about their past experiences. And it may be time to take a different approach to try to help them through the stigma and bias they've likely internalized over a lifetime.
Well, Dr. Galindo, I'd like to turn to you now and ask if you could share your thoughts about obesity as a disease and why its treatment is a key element of chronic condition management.
Hi, thank you, Jen, for putting all this together and having us discussing. So I'm very happy that we agreed to put K as a first step, because we need to kickstart, and the beginnings are usually the more difficult processes. And one of the key processes here is understanding that this is a disease, chronic disease, that it has an underlying defective pathophysiology. So it's not even normal. It is pathophysiology that we, I'm to blame, did not understand. We were ignorant about this for so long. And when you're ignorant, you usually blame your next door. And unfortunately, we have been doing that to our patients. So the scientific community and the medical community, because of lack of knowledge and many other factors, have been choosing the wrong way to tackle this chronic disease. So first, physicians need to understand that this is a chronic disease, that it has big implications. And then second, that treatment is needed because it's a chronic disease. So nobody will really do that. I would never see a cardiology treating high blood pressure by telling people go to walk, right? So the cardiologists don't play like that. So we need to take these to our side and use it to help our patients. Then what happened with the older population is they already have a burden of all their chronic diseases, and they have some specific situations that we're going to be discussing later. So it is always good and needed first to ask, can we discuss today about excess weight or making you have a healthier life? And then that would take the conversation toward next steps. But it's always good to think ourselves what we're dealing with, and then try to ask the patient if they're ready for that. So we need to keep that. We need to do the kickstart just by thinking about what we're doing. Thank you.
Great. Thanks, Dr. Galindo. The second and third steps in the toolkit are to assess for overweight and obesity and evaluate treatment options. And the interrelationship between overweight and obesity and chronic conditions is complex. Dr. Stanford, considering this complexity, would you discuss this relationship and the value of addressing obesity intently?
You know, I think that when a patient comes in to see me that's an older adult, I really think consciously about what their lived experience has been, particularly as it might relate to excess weight. And it's also important to note that over the lifetime, they may have accumulated weight. So if they compare themselves to their younger selves as a young adult, they may see some major differences in their body habitus, the storage of adipose or fat, like Dr. Starr mentioned earlier, and then that decline in lean muscle mass, which, you know, affects our ability to be mobile. So I'm sitting here, I'm thinking about this, and I'm having the patient really tell me their story. Their story is so important. For me to address any issues related to their weight, I have to hear their story. What are some challenges that they face? What do they think has led to where they are? And then I have to do a deep dive and not just look at the number on the scale. I need to evaluate their weight in the context of their entire health status. Do they have high cholesterol? Do they have high blood pressure? Do they have obstructive sleep apnea, diabetes? And the list goes on, because those give me a full sense of whether this weight is actually problematic for them. For different people at different sizes, we can see differences in health status. And so just taking that number at face value doesn't do the patient justice. So I really try to think about the complexity of what their story is, what their obesity and obesity-related diseases are, to begin to develop a plan that really treats the individual that's sitting in front of me, and not extrapolating their experience to anyone else's, but recognizing that their experience is indeed unique, and the therapies and modalities that I use in the order that I use them may be vastly different from the next older adult.
Thank you very much for that, Dr. Stanford. There are many treatment options and a growing number of resources for caring for older adults with obesity. Let's discuss some of these options and how working with older adults is different than working with younger adults. And Dr. Stanford, let's start with you. An important part of the treatment plan is the shared goals that the care team establishes with the patient. Would you share some insight on setting these goals?
Absolutely. But I think, I'm going to really amplify one word you said, which is shared, meaning that I have to agree, the patient has to agree, and we have to be on one accord. So what I really work on with patients is I introduce, concepts of potentially what their therapies can be. And often they may have resistance to one form of therapy or not. And I say, well, look, you're the one that would undergo this therapy. If you're not quite ready, let's try this strategy that you're comfortable with. And if we don't see that that's led to the outcomes that you're interested in, then we might progress to another therapy. And so that shared decision-making, letting them know that they ultimately have the choice to decide. Yes, I'm the doctor and I can give them some information to inform their decision, but ultimately the decision lies in the hand of the patient. That is so important, listening to their voice, where they're ready to go, and then helping them through that journey over time.
And then, Dr. Starr, what are some important nutritional considerations when developing care plans for older adults, including the issue of sarcopenia?
Absolutely. So one of the things that I have seen in my clinical practice is that, as we've already discussed and mentioned, that it's really important that we don't just tell an older adult that they need to lose weight. When that is told without any clear treatment plans, it really can actually cause more harm than good, in the sense that we can actually see restriction to the point that it's impacting loss of muscle mass. And when we think about, again, the aging process and those changes that occur with muscle mass, we can continue to see sarcopenic obesity, or the presence of both the disease of obesity with that loss of muscle mass, function, and strength. So one of the really big things that I really want to emphasize is the need for making sure that our older adults are hitting their protein requirements, making sure that they're getting in enough lean, high quality proteins that can help actually stimulate muscle protein synthesis. We do know that when we lose weight, we see that loss of both muscle mass and fat mass, and that distribution actually changes as we get older, where we actually start to see an uptick in the loss of muscle mass. So evidence is continuing to come out about the importance of making sure that we are meeting our protein needs, which particularly for younger individuals, that's not a problem. But for older adults, we're actually seeing that can actually be a problem, because they reduce the number of meals that they're consuming a day. So that's one of the biggest nutrition components that I want to emphasize here, along with a well-balanced diet. It's not just protein and that's it. We need to be thinking about the entire diet. But protein is one of the components that I want to emphasize, in the sense of helping us maintain that muscle mass and protect our older adult patients from making sure that they continue to be able to have that functionality as they continue to get older.
Great. Hey, and Dr. Stanford, back to you. What are some of the important physical activity consideration for older adults who are on a weight loss journey?
Absolutely. So I like to say that you can find your soulmate workout. What do I mean by that? It's about finding the activity that you enjoy, that you'll do and do consistently. So often when doctors give recommendations, they're like, you need to do X, Y, and Z. It needs to consist of this activity and this activity. Well, for example, if you were to tell me skiing is that activity, I would fail. miserably because it's not something I enjoy doing. So it's about listening to the patient, which things they enjoy, and helping them optimize those things. And then recognizing, much like Dr. Starr mentioned, that we're going to be losing lean muscle. And so we want to make sure some of that activity is focusing on maintaining as much of that lean muscle mass as we can, because we are going to see that decline regardless of how active and fit you are, just because of the normal physiology of the body. And of course, I have like a gradual titration, listening also to things, aches and pains, to make sure that I'm not emphasizing exercise that will only exacerbate those aches and pains. And that's really, really important. So for example, let's say someone has knee pain. I'm not going to tell them to go for a run on a treadmill. That would not be an ideal exercise in that situation. But maybe I can emphasize things like swimming, elliptical, or recumbent bicycle, which won't exacerbate that issue, but still allow them to get the level of activity they need to be really happy and productive in their physical activity.
And Joe, I'd like to turn to you now and ask if you could share a bit about the psychological supports that older adults might need when working to meet their weight and health goals.
Jen, I'm glad you asked me this question because I think if we thought about obesity care as a whole, I think there are a couple of areas that are often neglected. One is the pharmacotherapy that Dr. Stanford mentioned early on, but the other is this mental health support aspects of that. And in fact, when we ask employers and insurers and others to create comprehensive obesity care programs, the two areas we ask them most to fix their programs are around this area of mental health and the area of pharmacotherapy. And really, we have to recognize that many people who live with obesity have internalized some of the stigma they face throughout their life, and these issues have to be dealt with. And so giving them access to good mental health support, good psychological support is important here. And then also have to understand there are comorbidities associated with obesity, including depression and other mental health conditions where support is important. I think it is time for us to make it okay to ask for help for your obesity, and that includes asking help for not only the weight side of your obesity, but also the mental health side of it. Too many people forget that treating obesity is about quality of health, but it's also about quality of life. And so we want to make sure people are living the best lives possible, and seeking psychological care may be an important part of that.
And you again highlighted the complexity and the interdisciplinary nature of a care team. I think when you talk about the psychosocial supports and things that are needed, and we do certainly need a team approach for quality obesity care. So Dr. Galindo, I'd like to turn back to you and ask if you could address the rapidly evolving medical and surgical treatments for obesity. Could you talk about these options a bit?
Thank you, Jen, for the question. And first, I want to thank you, my colleagues, for introducing the topic that treatment needs to be comprehensive. So the fact that we have medical and surgical treatment does not eliminate what Dr. Starr mentioned about nutrition, what Dr. Stanford mentioned about physical activity, or what Dr. Nadolsky is mentioned about psychological support. We do have non-surgical treatments, medications per se, that are FDA approved, and we do also have surgical procedures that have been there for quite some time. And then we also have a strong scientific evidence to demonstrate that the benefit of either medications or surgery is beneficial, even in the older population. So there is plenty of data on this. What is not really there is good knowledge among physicians. And it has to do with all the evolving nature of this process. So we're learning as we do, and I think that we need to continue to educate. So I think that we need to work more on medical and surgical education, but overall, there are pharmacotherapy, there are oral therapy, there are tablets, and there are also injectables. We don't have the time to go one by one because that would be a different lecture, but there are different surgical procedures with different benefit and different safety discussions. And the way we do this is we present the patient and we bring them to in a conversation that is a decision-making, a shared decision-making conversation. There is no way a patient is going to be adhering to a long-term treatment for a chronic disease. And going back to the beginning, this is a chronic disease that is going to need long-term treatment. If you don't have them deciding along with you what is going to be that plan, there have to be some shared decision making for a long-term plan that is going to work. It's a one plan, it's a one medication, it's a combination. It may be more complex because of the heterogeneity of the disease.
So once again, I hear patient-centered, going back, and shared decision-making and patient-centered care. And again, the complexity. And Dr. Stanford, for this segment about our treatment options, I'd like to give you one final question, and that addresses guidelines. There are guidelines that primary care providers should follow in developing treatment plans. Can you tell us about these guidelines, including how and when several strategies that might be combined to support older adults to reach and maintain their goals around weight and health?
Absolutely. So one of the key guidelines that I would say is most widely used when we're addressing overweight and obesity is the combined guidelines of the American College of Cardiology, the American Heart Association, and the Obesity Society. And in these guidelines, we look at comprehensive care across a continuum, focusing on lifestyle and behavioral strategies, but also introducing the concept of pharmacotherapy or anti-obesity medications and surgical interventions. Now, I can tell you in my work with individuals, when I look at these guidelines, there's a specific emphasis on BMI, which is not my favorite friend. And the reason why it's not my friend is because BMI was never intended to be used in medicine. It was first a statistician that came up with this in terms of looking at Belgium soldiers in the 1800s. I don't think any of our patients will be those. And then subsequently for actuarial table data. And so we have to really look at the individual. And so the BMI guidelines, which definitely proliferate every guideline that exists, I think we have to take with a grain of salt. And I think look at the person in front of us. But these guidelines do emphasize that we can use kind of more intense forms of therapy, i.e. surgical interventions, for patients that have more severe disease. And then we will emphasize more lifestyle behavioral on those that have, minimal disease overall. And so, when the patient is trying to go with me in terms of deciding, it's about, like I said, hearing what the patient's interested in, hearing what their goals and strategies are, and then recognizing that their plan of action may change over time. So, but the guidelines will reflect making sure that you talk with the patient, look at their history of weight struggles, whether or not that, happened early in life, has been something that's more recent occurrence, and then really optimizing what the patient wants and listening to their goals and helping them to reach the happiest, healthiest weight for them.
Thank you very much. Well, the final step in the CARE framework is to refer the older adults for community resources, including those in their local community and those that are online. What resources are some of the things that you recommend for older adults that you're working with? Dr. Starr, let's start with you. What are some of the resources that you recommend for older adults?
Yeah, absolutely. And so for resources, I think Dr. Stanford hit the nail on the head in the sense that the resources have to match the interest of our patients. If they're not going to enjoy doing it, it's not going to be successful. So one of the things I want to emphasize is the need to make sure that when we present our resources, know that some of these things will work because of the interest of our patients whom we're working with. But there are a number of resources out there, both in our community and also that are offered virtually. I want to emphasize the YMCA is a great place to start for some of our really wonderful resources that are really targeted towards our older adults. I also would be remiss if I didn't mention our area agencies on aging that are throughout every state and offer a number of evidence-based programs that can really help our individuals have some of that accountability. And I think that that's one of the things that I constantly hear is I just need to have that support system. And these are some of the resources that allow that group setting support so that we can have that. There are also a number of virtual programs that are live and interactive. Vivo is a program that is a strength training program that's really designed to help support community, build strength, and also really kind of create that accountability for individuals. And so I would definitely just make sure that we look at the resources that are available, offer then be knowledgeable about those that are available, so that our patients and our clients can really pick and choose things that are going to help them and really targeted towards their interests.
And Joe, I'd like to ask you the same question. What are resources that you recommend for older adults on their healthy weight journey?
Yes, I would be remiss if I didn't start with my own organization, which is the Obesity Action Coalition, so obesityaction.org, where basically if you woke up this morning and said today's the day you want to do something about your obesity, we provide a wide range of resources talking about all the options that we've talked about. They're from the patient perspective, right? We're literally written so that we can tell you what the pros and cons of each of those therapies are. We're also a great resource if you're trying to engage in this and you're facing those barriers, right? You and your healthcare provider say, hey, you should do this, and then you find out your insurance won't pay for it. Well, reach out to us, because that's what we exist for, to create the advocacy to try to change that system. Another great local resource that I think folks, especially older Americans, would enjoy participating in is actually another charity called TOPS, or Taking Off Pounds Sensibly. And they do these wonderful support groups throughout the US, into Canada as well, that actually primarily participants in are older Americans. And so therefore they work and support each other in their journeys towards better health. So that's a great way to get community support. And I second all the other resources that Dr. Starr mentioned as well.
Well, we've had a great discussion here today. I can't thank all of you enough for your commitment to the care of older adults with obesity and the need to have this disease, and I again stress this disease, recognized for the complexity that it really is. And I'd like to just take a minute to ask each of you to share your final thoughts on supporting older adults to attain or maintain their healthy weight. And I'm going to start with you, Dr. Starr.
Yes, thank you. And thank you for this opportunity again. It's just been an amazing experience. I think the final thoughts that I want to leave with is that, obesity is a disease that really takes a team. It takes a team of individuals to really help support our patients, help support our older adults, and making sure that we have all the members on that team to really provide the support that our older adults need. The other component that I really want to emphasize is just making sure that we understand that our older adults really do have physiological metabolic changes that occur, and that we have to make sure that we keep that muscle in our forefront when we're treating our patients and helping our patients on this journey so that they can maintain that function as they continue to get older and have that quality of life that they truly want.
Great, thank you. And Dr. Stanford, I'm going to turn to you with that same question.
Absolutely. I think the key thing I want to leave, somewhat echoes what Dr. Starr said, and that's that obesity is a chronic disease. It's a chronic, relapsing, remitting disease that requires treatment over the life course, including in older adults. We've often neglected this population, and we really need to stop. It's gone on for too long. And then for those older adults that do come in, let's listen to what they're telling us. Don't assume that someone's not exercising or not eating a certain way just because you're looking at what the metrics show you. Our goal is to find out what they're telling us and to make changes accordingly. I think this is extremely important to really show value and respect and the dignity that older adults really need to receive. I think if we get that under wraps, that will be extremely important. And to recognize there's different modalities of therapy. It ranges from lifestyle to pharmacotherapy to surgical to psychological interventions, and the list goes on. And often the older we are, the more supports we often need, not the less support. And so I just think that if we can get all of these things in our brain and treat this patient population with dignity and respect, we'll go a long way.
Thank you. And Joe, I'd like to hear your final thoughts as well, please.
Yeah, I'd like to speak directly to our older adults right now and basically say, help exists, you deserve it, ask for it, insist upon it. There are teams out there that can support you in this journey and to achieve the best quality of health and quality of life that you can. You do not have to struggle with this alone. You likely have for most of your life, or you felt like you're alone during this, but honestly, evidence-based care exists and you can access it, so please ask for it.
Great message for older adults. Dr. Galindo, I'd like to give you the opportunity for your final thoughts, please.
Thank you, Jen, and my colleagues for working as a team for some time on creating this tool, the KAER tool from the GSA. And thank you, the GSA, for organizing this that will provide personalized care for our older adults with obesity. I want to just transmit a message that I learned myself as a practicing clinician. So the fact that we have newer therapeutic options and the fact that we have very effective therapies nowadays, either pharmacological or surgical, doesn't mean that our patients with obesity, a chronic relapsing and remitting disease, and I'm paraphrasing my colleagues here, does not mean that they have been struggling with dealing with a stigma and hearing again and again the saying that they were kind of to be blamed for, and that is not the way to go anymore. We have scientific evidence to support the fact that obesity is a chronic disease and it needs therapy. And our older adults have been dealing with long time the wrong concept on how to approach the disease. So that's that's one of the main points we're trying to do with this KAER tool, trying to change the paradigm that for a long time have been there and most of our older adults have been dealing with because they have been longer with this condition. So just want to transmit that message to our clinicians. They need to understand that our patients have been having that in the background for quite some time. Thank you much to the GSA for taking the lead and putting this into the to-do list to improve care for our older adults.
Thank you all. Just a couple of points that I heard over and over, and I want to stress them. The main, perhaps one of the main points is obesity is a chronic disease, and adding the complexity of older adults to that chronic disease certainly highlights the value of addressing obesity intently. I also heard over and over again about interdisciplinary care, that it does take a team and a team that really centers around that patient or that older adult in the middle of that team, and that the team addresses within themselves as clinicians and their colleagues the stigma and biases, and understand what that older adult with obesity has probably bringing into that conversation when they begin that conversation. It's certainly potentially a history of having been blamed rather than supported on their weight loss journey. And then I also heard the idea of treatment over the life course, just like we would treat someone with the high blood pressure that Dr. Galindo alluded to before over their life. For that, we're going to treat them for their obesity or overweight over their life as well. I want to extend my sincere thanks to all of you. I'd like to remind our viewers that our toolkit is downloadable, free, online at geron.org/obesity. We also have other resources there, including some great new podcasts that are coming. And so again, thank you to our panelists for joining me for this GSA Momentum discussion, and to Novo Nordisk for their support. Finally, thanks to everyone who's listening to the program. I hope you enjoy it and find that the GSA Toolkit for the Management of Obesity in Older Adults is a valuable resource. I'd love to hear from anyone who uses the toolkit about their experiences with it. Thank you so much for joining us today.